Good morning, good afternoon, good evening, everyone. Excited to see everyone for Neurology Morning Report. We already have a case, which is fantastic. Saki is going to be presenting us a case. And so we would need two discussants. Who would like to discuss a neurology case this morning? Ideally, one participant identifying as a woman and one identifying as a man. Who would like to discuss the case that Saki has brought to us? Who would like to discuss? Would anyone like to discuss a neurology case? If you're thinking, oh no, I thought it was just morning report, not neurology morning report. I wanted to discuss hyponatremia or maybe acute renal failure. That's okay. Here's a great opportunity to discuss a neurology case. Maybe you're thinking, well, English isn't my first language. Maybe I should. No, yeah, we have people here who speak Spanish and Portuguese, French, so many languages, so we can help you out if you don't know a particular word or need help language-wise. Anyone like to discuss? Every neurology morning report, we wait so long. All right, why don't we have Saki introduce herself? And that might inspire people to want to discuss with her.
Okay, so hi, my name is Sakhi. I'm an aspiring neurologist. I'm not a neurologist yet. I passed out of medical school last year. So for anyone who's in medical school, getting first year to final year, it's fine. I'm presenting a case. I just passed out. I'm one of y'all. It's I don't know if it's simple or if it's difficult, but it'll be fun, and I can guarantee that. So yeah, join in.
All right. Thank you for that enthusiastic introduction. Would anyone like to discuss Saki's case?
I'm happy to.
Great, Madalena, fantastic. One more discussant to join Madalena. And we'll be good to go. Who would like to join Madalena, Saki, and myself? We're so close. Mario, we'd love to have you. I know you've discussed many neurology cases, including diagnosing Balamuthia mandrillaris meningitis based on a skin finding, which was amazing. So we're happy to have you back. But just to give someone else a chance in case anyone was thinking, oh, I was just about to volunteer, since Mario has done it a few times. I know people are relieved, thinking I was just about to. All right, Mario, sold. Madalena and Mario, do you want to introduce yourselves? Tell us where you're from and what career stage you are in, if you don't mind, and we'll get started.
Sure. Hi, everyone. My name is Madalena Conti. I'm currently a third-year medical student in New York. I have recently finished both my psychiatry and neurology rotation, and I'm really excited to be here and to discuss the case with you all.
Amazing. Thank you so much for joining us, fresh off your neurology rotation. Great. And Mario?
Yes. Hi, my name is Mario. I'm a sixth-year medical student from Lima, Peru. And I always love to discuss, especially in neuro cases. So excited to be here again.
Fantastic. So excited to have both of you. So, and I think Chiara and Gabby are scribing and doing teaching points. So Saki, if you don't mind telling us just the chief concern in as few words as possible, and we'll go ahead and get started.
Okay. So the chief complaint is jerky movements in upper and lower limbs.
Jerky movements in upper and lower limbs. Fantastic. So Madalena, what comes to mind when you hear this information?
So jerking movements in upper and lower limbs. So one thing that I always think about first when I hear a chief concern is I want to know the time course. Has this been going on acutely? Is this more of a chronic picture? And of course, we don't have that time course right now, so that makes the differential very large. Some of the things that come to my mind, jerky movements can mean a lot of different things. They could mean something like a seizure. So I would want to think of the whole differential for seizures. Is this an acute intoxication? Is this something more chronic like epilepsy? So jerky movements could mean something like seizure. It could also mean something like hemibolism if you have a lesion in the subthalamic nucleus. It could mean, what else? Jerky movements could also, depending on how one is describing it, could be something like a tremor as well. So it's very large. So something I'd want to know more information about would be how long has this been going on? And I'll kind of stop there.
Fantastic. That's a wonderful discussion. So you're right, Madalena, if you tuned into our neurology morning reports before, you know that we always are looking for the localization and the time course, right? And those are going to help us solve this. And we don't have the time course, we just have the category of chief concern. And you're along the perfect track here. So what does it mean, jerky movement? So in real life, we would see the patient, right? And we'd already have a sense of what is going on, even as we're taking the history to get the time course and other information. But as you said, the main, two of the main categories, I can think of one third category of just abnormal movements, right? One would be seizure activity, right? Are these jerking movements, the tonic-clonic movements that are just being described as jerky, or other types of seizure we might talk about? I won't give away the name yet. Or is this a movement disorder, right? Is this hemibolism or bolism? It doesn't have to always be hemi, or a tremor. So big picture, we have abnormal movements, right, are being described here. And are these epileptic abnormal movements, or is this a movement, what we call movement disorder, right, which is our whole list of tremor and bolism and chorea and tics and all of those things. There's probably one other third bucket. Madalena or Mario, it's a little bit guess what I'm thinking, but what else could make sort of there be some abnormal jerky type movements in the muscles? Any other third category of neurologic sort of condition? We talked about seizure, we talked about movement disorder. Sorry, it's a bit of a guess what I'm thinking question, but.
Maybe something that's more localized to the muscle that's causing some type of muscle fasciculations of sorts.
Fasciculation, perfect. You got it, or you guessed what I was thinking, or some combination of both, which is fantastic. Right, so the other thing I would think of would be fasciculations. Right, and normally with fasciculations, the arm or the leg or the limb doesn't actually move, right? It's just a twitch in muscle fibers, but not enough to move the muscle across a joint. And something that could be epileptic or could be a movement disorder, depending on the physiology, would be a short, jerky movement that could move something across a joint. What type of movement would that be? A lightning fast jerk. You mentioned some movement disorders, bolism. You mentioned tremor. What movement disorder, or it could also be epileptic, would cause sort of a brief jerk of a muscle?
Something like a tonic-clonic?
So tonic-clonic is, so the tonic phase is going to be the posturing, and then clonic will be rhythmic jerks. But what about just sort of a brief jerk, lightning-like jerk that moves the muscle across the joint? So bigger than a fasciculation, but not rhythmic like a tonic-clonic movement.
Would that be something like myoclonus?
Myoclonus, perfect. So myoclonus is a lightning-like jerk, and that does move the muscle across the joint. So you probably felt this if you're falling asleep in a lecture, right, in medical school, our favorite pastime. Or if you watch somebody fall asleep, or even an animal fall asleep, your pet, or someone you live with, you watch them fall asleep, sometimes just a little shaking or jerking. That's normal. That's sleep myoclonus that happens sort of as we're going between sleep states. Hypnagogic and hypnomamic, one of them is waking up, one of them is falling asleep. I can never remember. And myoclonus can be epileptic, or it can be a primary movement disorder, or it can be, has a large differential. If we're talking about myoclonus, we'll get deep into that differential. But great, that gives us an excellent first pass here. Are we in a movement disorder category, an epileptic category, or fasciculations? Often pathologic fasciculations, like in ALS, the patients don't actually notice them. They're presenting with weakness, and you examine the patient and see they're sort of fasciculating all over. And some people, usually medical folks like us, when we see fasciculations, often right in the thenar eminence from texting too much, and we notice them a lot because we've learned that it's a signifier of bad disease. But usually, not always, but noticed fasciculations are generally benign, and patients with ALS are usually presenting with different concerns, and we notice the fasciculations. Great. Well, I think that's a great first pass. So I'll turn it over to Mario. As we start hearing the history here, Mario, what sort of things are on your mind that you're going to want to be looking out for here?
Well, I think if we think on this, especially the first two buckets we mentioned, the seizures or the movement disorders, I think age is going to be an important factor. Past social, family history and past medical history will also be important. For example, history of a parent having also jerky movements, and for example, thinking on Huntington's chorea or something like that. In terms of the seizures, are these movements recurrent, or is this the first time this has happened? And what is that? What is the pattern? We know it's upper and lower limbs, but is it more distal or proximal? Are there more like coordinated movements, or are there like erratic movements? And also, is there history of an organic medical condition? For example, I think we have had a case of hyperglycemia causing, I think it was hemibalism. I think it affects the basal ganglia. So any past medical history that could be associated with a secondary cause of a movement disorder. I think those will be some of the things that we're looking for.
Yeah, fantastic. Brilliant discussion, Mario and Madalena together. Absolutely. So yeah, we're going to want to know the age of this patient, whether this is, as Madalena also said, what's the time course? Is this something brand new? And if so, what has happened just before it? Systemic illness, new medication, intoxication, or otherwise? Or is this a chronic, or is this intermittent? All of the things we would want to know about the time course and context here. And then, yeah, you were sort of alluding to this, Mario, but when we, if this turns out to be a movement, so if we go down the seizure pathway, we'll have a lot to say about seizures. If this goes down the fasciculation pathway, we'll have a lot to say. But if this goes down the movement disorder pathway, usually we talk about localization, right? We've talked hundreds of times in this session, right, about weakness, and we say it could be anywhere from the brain to the muscle, and we have to work our way down, right? But movement disorders are a little different because it's pretty uncommon to say this movement disorder localizes to this structure. Usually it has something to do with the basal ganglia, though not always. And there are some disorders like hemichorea, hemibilismus, that can be caused by a subthalamic nucleus stroke. The STEP loves that, but it's actually not that common in real life. I've seen maybe one of them in 10 years. So, so with movement disorders, it's a little different. And the way I divide the differential is not so much localization, but asking, is this due to a structural cause? Is this due to a neurodegenerative condition? Is this due to a systemic illness causing the movement disorder? Or is this due to a medication or drug? It's usually going to be one of those four things. And so the differential diagnosis in movement disorders is first seeing the movement itself, because it can be really hard, even looking at it, to decide, is that a tremor, or is that polymini myoclonus, which can look like a tremor? Is that chorea, or is that a tic? Is that chorea, or is that a dystonic kind of posturing? So each of these movements, and then once you've decided what movement it is, it has a distinct differential in terms of, is there a particular structural lesion that can cause it? Relatively uncommon. Is there a neurodegenerative disorder? Huntington's was mentioned as a neurodegenerative disorder that causes chorea. On the other hand, Parkinson's disease does not cause chorea, right? It causes a tremor. And then there are systemic illnesses that can present with various movement disorders. And then, as with any differential for anything, right, medications and drugs. So for movement disorder, normally for neurology, I say localization and time course. For movement disorders, I usually say, what's the movement? And then it's going to fall sort of into one of these categories, and time course and obviously associated history are going to help us there. So those are some things sort of on my mind. We're going to want to hear the description of the movement. So in real life, we'd be seeing them and also understand them. So we might say, is that the movement you're talking about? Is it there all the time? Does it go anywhere else? As Mario said, what's the distribution? If this was always unilateral, that might make us think more of a structural cause, right? Although Parkinson's disease, idiopathic Parkinson's disease, almost always presents unilaterally and stays asymmetric for a long time, although it's not a structural lesion causing it. It's a degenerative process. So those are some things running through my mind, which are just a couple of tiny things beyond what you have already brilliantly discussed, both of you. Saki, tell us the history, and then I leave up to you whether you want to include past medical and all those things, or you want to withhold them. Up to you.
Okay, so the history is she's a 15-year-old girl who complains of diffuse body jerky movements for the last 4 to 5 months. She was independent in all activities of daily living and was a regular school-going kid till 18 months ago. She was a good student, and during the pandemic and the lockdowns, her school shut down, and effectively from 1.5 years now, she is not going to school because of that. No other symptoms apart from weakness during the febrile, no other symptoms apart from just being weak because of all of the jerky movements. And she has not continued schoolwork ever since. And she now needs help to do all her activities of daily living, which include eating, looking after her sanitary needs, etc. She can't even walk anymore. She was rolled into the clinic with a wheelchair, so she can't walk. Her jerky movements. Okay, so per her mom, she described the jerky movements to us, which is why I'm including it in the history. Her jerky movements last 4 to 5 seconds each time and seem to have a similar pattern. And during the jerky movements, she is conscious and remains clear mentally immediately, even after the movement and before the movement. There are no tongue bites, no urinary or fecal incontinence, none of those things related to her movement. I will include the past medical history and the medication, if that's okay with y'all, or should I wait? Okay. She did go to, so she is on olanzapine and valproate for the last 1 month, based on her previous doctor's prescription, who thought it was psychogenic non-epileptic seizures. But the movements have not improved after the medication, and they've probably it's sort of progressing. It's definitely not improved. And one last thing regarding the social history, she comes from a very poor household. That's it.
All right, lots of information here, but we still haven't seen the movement, right? A picture is worth 1,000 words, and a video for movement disorders is worth 1,000,000 words. And we know that Saki is going to have a video for us. Is a spoiler alert. Okay. So I think you had the first pass, Madalena, last time. So Mario, what are you doing with this historical information here?
Well, this is a very young patient, so neurodegenerative diseases will be pretty much at the last of our differentials, in my opinion. And there's one. I'm not sure if we're dealing just here with the jerky movements or also with a weakness component. I'm not sure, because if there was weakness, I'm not sure if the weakness could be just secondary to the fact that this patient is just in this movement constantly, or if there's also a more of a myopathic component. And we talked about fasciculations, that maybe the weakness could be the trigger of the jerky movements. I think that's less probable, but that's something I just came to my mind. The fact that this has been going on for, I think, almost 1.5 years, and it seems to have been progressing. Really, I think that's pretty a pretty ominous sign that maybe this disease is is gonna keep progressing. But I cannot. I think we had the two main differential seizures or movement disorders. I don't think I can still differentiate between both. If this was a seizure, this would be with preserved consciousness. I think that maybe that would be we could begin trying to add specifiers to the description, but I'm not sure if we can do that differentiation just right now. So that's what's in my mind right now.
Yeah, I agree with all the questions you've asked, right? It's very hard to diagnose movement disorders on descriptions. What's that quote? Talking about music is like dancing about architecture or something like that, right? This is like, we should add to that a phrase about talking about movement disorders without seeing them. But yeah, you're asking a couple of interesting questions, right? Which I'll highlight. One is, what is this weakness about, right? Does this patient have a syndrome of progressive weakness? And because the limbs are so weak, the attempts to move them, it's like if we do hard exercise, right? There are certain positions where your limbs start shaking, right? Because it's under too much stress, or I don't actually know what the physiology of that is, but it happens, right? So is there a weakness here? And the sort of tremulousness is an attempt to move with weak muscles. I've seen sometimes patients look like they have ataxia, but actually just the arm is weak, and you can tell that they're actually precise, so they're not ataxic. It's just the weak arm is sort of tremulous, trying to move, just as we would be if we have normal strength but are doing something that's too heavy for our muscles when we're exercising or something like that. And then the other possibility is just, sometimes the initial description of many symptoms is weakness by the patient, right? Which is just their way of saying they're not moving normally, and they say it feels weak. And that could be numbness, that could be Parkinsonism, that could be ataxia. So is it just that these jerking movements are making it hard to move, and the patient is describing these as weakness? Or is there some underlying process that is causing both weakness and some type of superimposed movement disorder? Those are sort of the three ways to either connect those dots or have one arrow pointing to both, right? Or have them all pointing to each other, or how you want to think about that. As you said, if there are seizures, if it's really the whole body and the patient is awake, right, then this is not a generalized tonic-clonic seizure, because a generalized seizure means both hemispheres are involved and consciousness can't be preserved. So somebody, as Saki told us, looked at the patient and thought these were psychogenic, non-epileptic seizures. A very difficult diagnosis to make, and there are sessions in neurology conferences where epileptologists will show the video and say, vote, is this a epileptic seizure or a psychogenic non-epileptic seizure? And it's really hard without EEG on there. So you can see the history being set up here, saying, oh, the kid has been home from school and the kid's not seeing anyone, and during this period developed these movements and is now in a wheelchair, but is having abnormal movements with preserved consciousness. You can see someone building that case. But if this patient is having myoclonic seizures, so there's a condition, juvenile myoclonic epilepsy, this patient probably presenting a little late, but not impossible, that has the triad of generalized tonic-clonic seizures, myoclonic movements, and absence seizures, I believe. I'm not a pediatric epileptologist, but digging somewhere in my board studying many years ago, but they often have myoclonus in the morning. They drop their toothbrush and they have sort of little extra twitching movements in the morning. But this is more diffuse than that, and there hasn't been any superimposed seizure. So I think we're still where we started, right? As Mario said, is this a movement disorder? Is this epileptic? We've heard there's no tongue biting, incontinence, et cetera. So these are not generalized tonic-clonic seizures, though you don't always see all of those things with those. So so this is challenging. When you said olanzapine and valproitis, everyone's eyebrows go up. Has this patient been on these medicines and now has some type of movement disorder as a result of those? But these have been used to treat this condition, albeit ineffectively. Just while we're on that topic, are either of you able to tell me if this was a different case, right? Olanzapine or valproate, what movement disorders, if any, could they cause? Does anyone know? So again, not the case in this patient, right? But since we might be wrong, we might see a video and say these are seizures, but while we're talking about movement disorders, what can either of these medicines do?
Is this, yeah, sorry, I didn't know if I was mute.
Let's see. So for olanzapine, I believe that's a second generation antipsychotic. And I know that if we're comparing second generation to first generation antipsychotics, generally second generations have less extrapyramidal symptoms. However, they still can cause them. So things like, so that's kind of what I would be concerned about with a patient on olanzapine, some extrapyramidal symptoms.
Yeah, that's exactly right. So sometimes I get referrals from the psychiatrist and they say, this patient shouldn't have drug-induced Parkinsonism because they're on a second generation. Madalena said it perfectly. The risk is much reduced, but the risk is still present for patients who use these anti-dopamine agents for longer periods, or sometimes not even that long. And it's usually, well, there are many things you can get. You can get tardive, fill in the blank, tardive dyskinesia, tardive tremor, tardive dystonia, a drug-induced Parkinsonism. And then valproate, very uncommon, but can cause drug-induced Parkinsonism in prolonged use. It is one of the sort of last ones on the list of things that can do that. I have no idea what the mechanism is, but it has been described, and I think I've seen maybe one case, so something to keep in mind. But again, not the case here. The movements preceded the drugs, but we always have to look at the drug list when we see movement disorders, and these two drugs are on the list of ones that could cause things like that. Okay. All right. So I think we need to see what this looks like to have any further discussion. So what would you like to tell us or show us next, Saki? Actually, we should ask, you mentioned and then corrected febrile illness. Is that something you didn't want to reveal, or was there anything preceding this aside from being sent home from school for the year?
No, it was just, we can just ignore that point.
Okay, we'll just ignore.
Yeah. So yeah, one thing that I had to correct was 18 months. I think someone mentioned 18. I think Mario mentioned 18 months. Her school's off since 18 months. We know of her movement disorder only for the last 4 to 5 months.
Okay.
That's just something I wanted to point out.
Okay.
Yeah.
So for 14 months home from school, she was fine, and then last 4 months she's developed progressive weakness and this abnormal movement.
Yes, per patient. Yeah.
Got it. Okay.
Okay, so I'll start with the physical exam, and then I can describe the movement in words and then show the video as well. Does that sound like a good plan?
Let's do this. Why don't you tell us everything on the exam except the movement, and then why don't you show us the video, and then we'll have Madalena and Mario try to describe what they're seeing.
Yeah, that works. Yeah, that works.
You're a future neurologist. I know you will describe them eloquently, and part of that for us will be deciding how we describe them and see if it lines up with you and your colleagues there.
All right. Okay. So for the physical exam, the exam was interrupted with constant jerky movements every 15 to 20 seconds, especially when she was asked to carry out a particular activity like raise her arms or legs. She was afebrile. Her blood pressure was 120/80, respiratory rate was 13 per minute, and SpO2 was 98. The general exam with respect to the respiratory, cardiovascular, skin, it was all fine. It was all normal. The patient is alert, conscious, and cooperative. Her cranial nerves are normal. For the motor exams, again, cranial nerves with the constant jerky movement, it was difficult, but what we could make of was normal. Motor exam, the bulk, she was undernourished, but there was no specific area where there was atrophy per se, but she was undernourished overall. And so the tone was slightly it was diffusely spastic in the upper and lower limbs, symmetrical, and no variation in the upper and lower limbs with respect to the tone. The power in the upper limbs was 3 out of 5, and this is symmetrical, and the lower limbs was 4 out of 5 in the left and 3 out of 5 in the right. With reflexes, she had diffuse hyperreflexia in the upper and lower limbs. And her planters were equivocal bilaterally. Sensory exam was normal. The coordination, we were unable to ask her to do the coordination because, again, the jerky movements are interrupting, but so that we couldn't do that. And the eyes, we always examine the eyes also. Would you like me to say that exam, or would you want me not to say it? I can.
Will we be able to see it, or you want to tell us?
No, you won't be able to see it. So
okay, yeah, then please tell us. Yeah.
Yeah. So there was no ataxia, and there was no nystagmus, and there were no KF rings, none of that in the eyes. So yeah, and the skin is fine.
KF rings, yes. So this is a condition I still have not seen except on the boards. It's Wilson's disease. When you hear about a movement disorder in a very young individual, Mario had said earlier, it shouldn't be a degenerative condition, but unfortunately there are neurodegenerative conditions of childhood and inherited conditions that are sometimes not inherited, they're germline mutation. So we would have to think about Wilson's. I believe I've never seen a case, as I've said, it's on my, what I call my neurology bucket list of things I hope I will see someday. So I have an image in my mind of what to look for, but I think it's usually Parkinsonism, dystonia, tremor, not the types of things we're seeing here. So before we see this video, either Madalena or Mario or both, what does some of this new information tell us here?
Yeah, so there's a lot of rich information here. And I think, in my mind, I'm trying to go through all this really important details and try to make sense of one common picture. One thing I just want to say from the last aliquot that I didn't get a chance is, it's pretty striking that this patient was independent in their ADLs, just a few months back, and all of a sudden has really degenerated to a point where they are very dependent on others for their living. So I think that's just something that really stood out to me and is very concerning, that her ability just to perform daily activities has worsened so severely. So I definitely am concerned about this patient. So in terms of the new information that we've gotten, so the fact that she's undernourished, that to me makes me more interested in, is she deficient in some essential vitamins or other sources that could be causing some of these symptoms? So that's something I would, is a little bit kind of on the back of something I'm considering right now. We talked about localization a little bit, and so I'm trying to think, could this be localized to an upper motor neuron or a lower motor neuron process? The fact that there's diffuse hyperreflexia is making me think that points more towards an upper motor neuron process. What else here? Symmetrical strength, 3 out of 4. What's also interesting is that we've mostly seen that this has been a symmetrical process up until now, and still most of the motor exam is pointing to a symmetrical process, except for the lower limbs where the right side seems to be weaker than the left. That's something that I'm curious about, because the rest of the information we have isn't pointing to a symmetrical process. What else here? I think the vitals, nothing stood out to me there. That the patient seemed, in terms of her vitals, relatively stable here. So I'm interested to get more information. Mario, I'm not sure if you have other thoughts to add.
Not much really. Just the fact that the movements these jerky moves are every 15 seconds. I'm not. I think we need to see what type of movement that is, but I just can't imagine this patient being like this for 4 months. It seems pretty severe. But honestly, I also think we have a motor component to the process here, and where that overlap between the jerky movements and this parallel upper motor neuron problem is, maybe that's where the answer is. But for now, I have nothing more to add.
Yeah, fantastic discussion again, Mario and Madalena, really fantastic. So yeah, we need to see the movement, as we keep saying. We keep putting that off because that's obviously going to take us down a particular pathway. We want to make sure we don't ignore any of the other information, even though this is the opposite of what we'd be doing in real life. We'd be seeing that movement and saying, oh, there's some hyperreflexia, but I'm trying to figure out what this movement is. So it's kind of an interesting thought exercise. And what we're seeing, as both of you said, is upper motor neuron findings, right? There's increased muscle tone as far as spasticity. There's hyperreflexia. So there's something going on here in the motor system, in the central nervous system, brain or spinal cord. Saki, did you say her mental status completely normal, the child? Cognition totally normal?
Yeah, so we just asked her where she is, what she's doing, just the basic 3 questions, and that was fine.
But she could give the history and other aspects. And
no, so her mom was giving the history.
But as far as you could tell, and no report of, so that helps, right? Because if we're seeing a diffuse, mostly symmetric, though as Madalena says, a little asymmetric, not sure, as you said, you're curious about it. I'm curious about that too. But in general, it seems to be a grossly, it's not one side is everything and the other side is nothing. It's a process that has some asymmetry to it, but is overall diffuse. If we have progressive upper motor neuron signs and there is no change in the mental status, where would that put us localization-wise in principle? So if we have bilateral weakness with upper motor neuron signs and we're not hearing about any changes in the cognition or mental status, where would we localize that to? Not worrying about the movements for a moment.
So like spinal cord?
Yeah, it should be the spinal cord, right? So if we have upper motor neuron signs, we're either brain, brainstem, spinal cord. If we were in the brain and we have something so progressive and diffuse that it's causing bilateral weakness, or diffuse in the motor pathways, we're either bilateral motor cortices or some diffuse white matter process, probably we would imagine that we should see some cognitive changes as well. Although if the child is not in school and maybe on simple questions and the mom gave the history, maybe we would miss that. Brainstem, if there's a progressive process there, cranial nerve deficits, right? Probably, possibly even altered level of consciousness. So what's left? The spinal cord. A diffuse spinal cord, a process causing, I should say, a progressive severe spinal cord process causing this degree of weakness with no bowel or bladder. It's a little hard to know what to do with that. And it's a little hard to know what to do with spinal cord plus movement disorder, right? You can get, if this is myoclonus, there is cortical, subcortical, brainstem, propriospinal, and peripheral even causes of myoclonus. One of the first neurology morning reports, someone presented a case of localized myoclonus that was just due to cervical radiculopathy. So a common condition causing a rare presentation. So you could link them that way, but a little confusing here for sure, as you both acknowledged. I'm not a pediatric neurologist, and in general, I don't know if there's any pediatricians or pediatric neurologists listening today, but in general, when students ask me, should I go into adult neurology or pediatric neurology? And they're sort of interested in both. And one is, of course, do you like taking care of children or do you like taking care of adults and those things? But the other that I realized later, because as an adult neurology resident, you do about 4 months of pediatric neurology, is that the thinking process in general, though it changes case to case, is somewhat different between these two. In neurology, adult neurology, we're really thinking about localization for the most part. Where is this problem in the nervous system? And that has its differential. And in pediatric neurology, it's much more about syndrome identification. So we'd be making rounds in the newborn nursery and the person would say, oh, they have low set ears and hypotelerism, and they have, all the step 1 things, musky smelling urine and all of these things. And you say, oh, this is so-and-so syndrome. And I remember there was one pediatric neurologist who would say, this child has X syndrome. I'd say, oh, again, that's not a real syndrome. They would say some name. I say, I've never heard of that. And they would take this book and leaf through it and say, it looks just like this kid. That just looks like a kid. What's wrong with the, I can't tell. So there is this sort of difference in mindset, and a pediatric neurology discussant might say, this age of onset with this movement disorder and spasticity, it's one of these 4 syndromes, right? None of that is immediately jumping to mind in my case, because I don't know many of these syndromes. That being said, this is a really fast-moving thing. 4 months is not acute, right? But it's certainly subacute, and doesn't sound like one of these devastating chronic progressive inherited conditions of childhood leukodystrophy or something like this, though certainly on the differential, and I'm not expert in these to know how they can behave, but it seems to be moving a little bit quickly for those types of degenerative syndromic type conditions. And so we would have to think about other etiologies. Okay, we've stalled long enough. Let's see the video. Saki has gone through the process of getting consent from the patient, and since the patient is a minor, from the patient's parents to show the video. So we're grateful to the patient and their family for letting us learn from this condition. All right, I think I've co-hosted you, Saki, the moment we've all been waiting for.
So Kirtan's going to show the video. Sent it to him.
Okay.
Aaron, can you see that?
Yes.
Then I would hit the play button. All right. Aaron, do you want me to play it again once?
Yes, please.
There's another video. Kirtan, you can play the other one as well.
Oh yeah, maybe let's see the
Yeah.
other one.
Yeah, actually, I don't have that one right now because it was, troublesome, but maybe I can play this one for a part now.
Sorry.
So feel free, Madalena or Mara, to just describe what we're seeing. All of us have our eyebrows furrowed, myself included. What would you just describe? And that'll help us, I think, say what this might be, although I'm not really sure either. And do we have the other video somewhere, Saki? I think I've made you a co-host if you want to show us.
You can give me 1 minute. I think
Yeah.
if y'all can describe, I'll try and get the video.
Okay,
I'm
sure. Just
getting-
keep it playing Kirtan as a loop and we'll try to describe it. What are you seeing here? This is difficult.
So just to make sure, this patient didn't have loss of consciousness, right? That wasn't described because what I see is like she almost like loses her postural tone and
Yes.
like she would like almost pass out. I didn't see like the jerk. I was in my mind I was expecting almost like some type of jerky move. So that was, for me at least, somewhat unexpected. I'm not sure what I can do about that. I'm not sure if there's another way to describe it.
So to answer your question, before and after the movement, she had no cognitive deficit, and even during, I mean, she'd just close her eyes. We don't know if she'd be lucid, per whatever we could understand, whatever what's happening.
Yeah, she does look like she almost smiles a little bit after, as if
Yeah.
she's aware that something
Yeah, exactly.
that normal happened to her. So it looked like consciousness was preserved. What are your thoughts, Madalena?
Yeah, I agree with Mario that there does seem to be a loss of postural tone, and as Saki described, they're very, very brief episodes. So she seems to, be asked to be holding her hands out in front of her, and then for just a few seconds, it almost appears as if she's jerking backwards, and has her eyes closed and has these just few seconds of I'm not sure what word to use, but of convulsions or shaking of some sorts, and then kind of returns to a baseline. And as you said, she was smiling almost as if she is aware that something has occurred.
Yeah. So
I do have the video if yeah.
Sure. Yeah.
Okay.
Great.
Yeah.
So you're pulling that up. Yeah, it looks like the movement is extremely brief, right? Okay, let's see.
Sorry, I'll just
Go ahead. Go ahead.
Y'all want to listen to it? Y'all could listen to this. That's it.
Can we just watch that one more time? I think this
Yes.
one has something a little bit different for us. Okay. So going back to the first video, those are very brief, sort of almost lightning-like, right? And they looked like a loss of postural tone, right? Rather than a positive movement. So these look to me almost like full body asterixis, which is not something I've seen before. Asterixis, we usually think of the patient puts their hands out and they sort of twitch like this. And we always learn in medical school that's liver disease. This is completely non-specific, right? This is, people call it the liver flap, I think was the old term. This is just usually almost always toxic metabolic dysfunction. And there's these, people sometimes call it negative myoclonus instead of positive myoclonus. You have these sort of brief lightning-like jerks of loss of postural tone and then writing. Almost looked like that of the whole body, looked sort of in the family of myoclonus. Second video looked like something a little different. How would you describe that, Madalena or Mario?
Yeah, so similar to the first video, they were very brief, so still a few seconds. And in the second video, it appeared that it almost began in the legs. So there would be a brief jerky movements in the legs, and then I believe her left arm would jerk, but her right arm seemed to just, she was seated in a wheelchair and her right arm seemed to be resting and not as involved in the jerking movements. And she did, I believe, if I remember correctly, in the video for those, 2 to 3 seconds where it was occurring, her eyes would close. And she again appeared to be no loss of consciousness as well. Yeah, Mario, other thoughts?
Just I think I also saw that both her legs deviated to the right. I'm not sure if that's because she was seated that way or maybe her legs. So that's one thing to add.
Yeah, she was sitting in a posture that I also wondered it was just how she happened to be relaxing in the wheelchair, or was it an abnormal posture? The second video, there was a moment of what happens where it almost looked like the hand and mouth had a brief dystonic kind of posture. It almost looked to me like a condition that is much more common in older men, which is the LGI1 receptor antibody syndrome, which causes faciobrachial dystonic seizures, although it's not clear if they're seizures or movement disorders. It's one of the relatively newly described antibody-associated syndromes. Almost always older men, usually not associated with an underlying neoplasm, and there's often associated hyponatremia. And it's just a very brief face and arm, face and hand, little sort of dystonic, very brief dystonic movement. And the patients, if this isn't recognized, can go on to develop an autoimmune encephalitis. So if it is recognized, these are can be very steroid responsive. But I've never heard of that in a younger person, and I wouldn't know what to do with the hyperreflexia and spasticity. And the first video didn't look like something different. So I guess sometimes it's helpful in movement disorders. This is ambiguous, right? What is it not? It's not chorea, right? We don't see sinuous, irregular, large amplitude movements, and ballism and athetosis are just in the spectrum of chorea. It's not a tic, right? Some people might say that looked pretty short and it's sort of complex. Could it have been a tic? Usually a tic looks something like, usually a tic looks like something you could do. This is sort of my way of thinking about it. Those movements were really fast, right? You could maybe imitate that in your own body, but they look like something going faster than what you could do, right? There being some abnormal discharge in the brain. A tic is generally can be fast, but it's a more complex, sometimes less stereotyped, though can be stereotyped movement. And the patient generally reports a premonitory urge that they feel a need to do this movement, and then a release when they perform the movement. So patients can learn to control these. Oliver Sacks describes a surgeon with Tourette's syndrome who is also a pilot. And the experience of flying with him, I forget which book this is, which Oliver Sacks book this is in. And he's wondering what it's like for the surgeon to operate, knowing he could have a tic. And then after he leaves the operating room or after he lands the plane, he says, like, I have to let all my tics out now. So when they're controlled, there's a sense of buildup and need to do them and release. But these don't really look like tics. The second video, they looked almost a little bit dystonic, but so brief. So I don't know. I'm with you both. I'm not sure what these are. So let's put them aside for a moment, and the fact that they're associated with spasticity aside for a moment, and just think about this time course, which is one of the first things Madalena brought up. This is a new neurologic thing. We haven't decided what it is yet. Emerging over 4 months. What types of conditions would you put in that category in terms of just broadly?
So this will be like in the subacute to chronic category. I think always toxic metabolic. I think we mentioned micronutrient deficiencies could be a possibility. Not sure which ones. Autoimmune or inflammatory conditions. I think you mentioned, Dr. Aaron, an encephalitis, but maybe encephalitis would have more of a also like an altered metastasis component to it, at least. Maybe there are exceptions. Besides that, some structural or, but I think we will have more of a localizing picture. And lastly, malignancies. I think usually we also would like to see more of a focal process, but I think maybe in those categories we could be thinking about.
Yeah, I think that's right. This is subacute, right? It's fast, but not acute, and it's probably not long enough to be chronic. It's moving along pretty quickly. It's progressive, and it's over months. So yeah, inflammatory conditions. You're right. If there was a neoplasm of the nervous system, we would expect maybe a more focal process. If there was a neoplasm outside the nervous system causing the inflammatory process, in kids, the common one would be opsoclonus, myoclonus, ataxia. This patient doesn't have opsoclonus and doesn't have ataxia. That's usually associated with a neuroblastoma in kids. But maybe they have just the myoclonus. And they have a paraneoplastic immune-mediated condition. I agree, we could think about toxic metabolic in this time course, but what toxin, what metabolite would cause this syndrome? Anything could cause myoclonus, but with spasticity, and with that other thing in the second video, I'm not sure what that is. So it's, and then vitamin deficiencies causing movement disorders, none are sort of leaping to mind for me here. Many neurologic syndromes can be caused by vitamin deficiency or nutrient deficiency, but movement disorder with that, having trouble thinking of one. So the question would become, if we're seeing this patient, and this is where we are thinking sort of inflammatory or maybe some type of toxic metabolic, though not entirely clear, what tests would we order to try to sort this out? So what tests are we going to ask for from Saki here? So I guess one thing that would be helpful in deciding in moving that part of the discussion along is, if we're saying this could be inflammatory or maybe toxic metabolic or less likely structural, what inflammatory conditions or what toxic metabolic or what structural things would you be looking for? And those are the tests we could think about sending.
So some tests that I would definitely want to get are even just some basic labs, like CMP, basic metabolic panel, just to see if there are any electrolyte abnormalities. I know we could check an ESR and CRP, and I know those are pretty non-specific markers, but they would clue us in to see if there is some sort of inflammatory process going on. So just some basic lab work is definitely something I would want to start with.
Yeah, definitely basic lab work. And if no clues there, what other things might we want to be thinking about? So I guess one question will be, what is our actual differential diagnosis here, right? So if we frame a problem representation of a subacute movement disorder in a 15-year-old woman, what things might you think about there? What if I just said subacute movement disorder in a child?
Something we haven't talked too much about yet is if this could, if there's an infectious etiology, if this could be a post-viral process or just post-infectious process. We didn't get too much, we got nothing from the history in terms of a recent viral illness in the past, but that's something I would definitely want to ask the parents or ask the child if she is able to give that information. So you could get just something like a viral panel as well to see if something comes up there.
Any particular post-infectious movement disorders of children that you're thinking of?
So it's challenging because I think we said that this does not seem to be chorea, and I know that rheumatic fever, you can have a component of that would be Sydenham, I'm not sure if I'm pronouncing that right, Sydenham's chorea. So that's something that has been on the back of my mind for a little bit. I don't think the video quite fits the chorea picture, but that still is, I believe, on the differential. What else? Mario, do you have any other thoughts of infectious processes that could present like this, post-infectious processes?
Not really. We could order an anti-streptolizing titer. I think
Yeah, exactly.
But I mean, I think group A strep also can cause other neurological problems, but not isolated movement ones. I think Sydenham's chorea would be the only one would come to mind. I think I think PANDAS or something, an acronym called. But I think that they'll have more of also psychiatric components. Other post-infectious processes, not really.
Yeah, so I think, again, this is where in complicated cases, sometimes they just zoom way out and say, new movement disorder, young child, right? What comes to mind? And Sydenham's chorea comes to mind, but you all said, but this isn't chorea, right? But in that family of this time course, this type of presentation of post-infectious neurologic syndrome, I believe in the family of Sydenham's, you can also get tics. And so I'm going to presume you could also get other neurologic disorders. And you might say, well, we don't really see Sydenham's anymore, maybe not in the United States, but many of our folks who are here this morning who are practicing or learning in other parts of the world see this somewhat commonly. When I've done consults on international telemedicine platforms, this is something definitely that is seen, because the threshold to seek care for a sore throat may be lower if you have to travel a long way, or the cost or whatever, whereas the threshold to seek care in the US might be, the threshold to seek care would be higher, right? And here is often lower from the first symptoms. So someone might go through strep throat or something without treatment. So yeah, that's sort of what I would be thinking is something in the post-infectious inflammatory category here, and want to know about whether there were preceding illnesses. And I guess in the other inflammatory category is, like I said, and if you told me a child with a new movement disorder in this time course, I would say, oh, is it opsoclonus myoclonus ataxia syndrome with neuroblastoma? Well, this patient doesn't have that, but they have a subacute movement disorder that has some myoclonus. Again, maybe it's some form fruste of that type of syndrome, and presenting with part of it so far. The spasticity I wouldn't know still what to do with. So those are sort of the things I'm thinking, and you could get a lot of labs that would be normal. I think an ASO titer would be helpful. I'm not sure we would see anything on neuroimaging, though if we did, it would be interesting and helpful. And then if we've struck out with everything, could think about looking at spinal fluid, I guess. These are not psychogenic, non-epileptic seizures, right? That's pretty clear from looking at them, because they don't even really look like seizures, let alone psychogenic. I'm trying to think of other things. Again, this is not chorea, as we've all said. If it were chorea, there's a long differential. There's chorea gravidarum, chorea in women who are pregnant. There's hyperglycemic chorea. There's chorea you can get from antiphospholipid antibody syndrome. So again, this is not chorea, but it's a subacute movement disorders, making us think of an inflammatory category. Antiphospholipid antibodies, I guess, would be something else we could send. And then we'd want to do a detailed family history. Does this patient have some type of degenerative condition, inherited condition? People have mentioned Huntington's. When Huntington's comes on this early, so it's a trinucleotide repeat disorder, right? So it has anticipation, comes on earlier in each generation. When it comes on early in children, the juvenile variant called the Westphal variant, actually they usually present with Parkinsonism rather than Huntington's disease, is my understanding. I've never seen one of these cases. And then I guess people have mentioned Wilson's. That's sort of always on the differential for a pediatric, or young onset, I should say, movement disorder. So family history of preceding illness, streptolysin titer, those are the things I'm thinking. So anything else before we hear Saki tell us what happened next? All right, up to you. You can, if one of these tests comes back and gives a diagnosis, you can finish it. If there's a bunch of tests and you want to withhold the last one because I leave it to you to
Okay.
create the dramatic arc of the remaining minutes here.
Okay, all right. So with the labs, I think the imaging, we got an MRI of the brain, which was normal. An EEG was insignificant. It did not really reveal anything. Labs with respect to a basic CBC, RFT, LFT, they were all fine. We got an ASO, we got a chest X-ray. It was all fine. ECG was fine. Echo was all normal. The next morning, interestingly, when I went to meet her, I actually ended up spending a lot of time on the previous day with her while talking to her. And she was very nervous with getting hospitalized and everything. So the next morning when I went to check on her, she didn't remember me. And we spent a lot of time the previous day. So it struck me as to why she didn't remember me and how she was how she seemed to be lucid the other day. And that's when I asked her mom, is this normal for her? She was like, oh yeah, she's not been going to school, maybe that's why, or something like that. So that was an interesting kind of a symptom, and that's when I thought that there might be cognitive issues as well in this patient, which were just kind of ignored or neglected because of just not practicing them. She's at home, what will she do, essentially, I think. And so that's when I asked her one question which you all already raised about a febrile episode for rheumatic fever, because that was one thing that I was thinking about. She did have fever 8 months ago, but she got tested for COVID and it was fine. There was no other joint pain or anything associated with the fever, and so but her ECG, echo, ASO, they were all normal. So yeah, so now we've ruled out Sydenham's chorea, and the autoimmune panel that we sent was also negative. We also sent labs for a urine copper and a ceruloplasmin, which was to rule out Wilson's, which was also negative. There was one last test that we did, which was in the CSF that I'm not going to say right now. But I just before that, I want to say one thing. The movement disorder that she had, it can perplex, like the movement that she had, it can perplex anyone who's not seen it or not read about it. I would have not known what it was had I not just read about it 1 week before, and I would have been equally confused. And so it's actually called slow myoclonus. So myoclonus is typically just a few it's milliseconds, maybe 1 second, not more than that typically. But what she has is more than a few seconds, but we could not qualify it to the Bullismus category. Movement disorders are classified as to how long they last. So she had slow myoclonus, and only few conditions have been reported to have a slow myoclonus. So that's a hint that I'm throwing out.
That's a hint if anyone is a specialist in pediatric movement disorders this morning. So we were in the family of myoclonus. That second movement looked to me a little bit like dyskinetic or dystonic, actually, in the second video. But all right, well, anyone want to guess what that last test was?
So yeah, we have cognition and we have slow myoclonus. Yeah. I think that just wanted to say that. Yeah.
Yeah. So, coming back to our earlier discussion, we asked, is there a cognitive dysfunction plus spasticity plus a movement disorder? This starts to sound more syndromic, and you'd wonder maybe about a leukodystrophy or what are these? The pecan, McLeod's, all of these iron accumulation diseases, eye of the tiger. These are things for the neurology boards that you'll never see in real life, or you'd go decades without seeing one. As we said, if we don't find anything on here, we would probably look at imaging. That was normal. We would probably look at CSF. And maybe you can at least tell us, Saki, the parameters of the CSF without telling us your final diagnostic test, just the protein, glucose, and cells. Oh, I think you're muted.
Sorry. So the protein was elevated mildly. It was around 60, if I don't, 60. There were increased lymphocytes, no red blood cells. Yeah, that's it. Glucose was fine. Normal.
Okay, so non-specific, mildly inflammatory CSF. Yeah, the differential diagnosis of myoclonus, toxic metabolic is the most common etiology we see in the hospital, patients in renal failure, hepatofailure, on medications that cause myoclonus, or in the setting of renal failure, hepatic failure, not clearing their regular medications and get myoclonus. This is not the case here, right? And then we're sort of in what are our other categories, right? Structural, causing diffuse myoclonus, no, and we already saw the imaging, and the answer was no, right? So either a systemic illness or neurodegeneration, and we've already ruled out all the systemic illnesses. So what neurodegenerative etiologies of myoclonus in adults? We always think of Creutzfeldt-Jakob disease, but actually myoclonus can occur in Alzheimer's, that can occur in corticobasal syndrome. And then there's all sorts of rare pediatric Lafora body disease, neurocerulopofuscinosis, things I studied for my boards and I've never seen. Unverricht, Lundeborg, there's all these super rare syndromes. I divide them for myoclonus and degenerative into ones that cause epilepsy and ones that don't, but I'd be hard pressed to make a list of them. So I guess if there's no real signal of inflammatory, or it's mild and I'm not sure what to do with it, I guess we're putting this in some type of rare degenerative disorder. But okay, Saki, anyone, Madalena, Mario, can you guess what this last test is? Or do you know? I have no idea.
I was just wondering, in the imaging, did you get a diffusion weighted imaging? Because what I've read is, when I heard the memory, the cognitive, that I interpret as cognitive CJD came to mind with myoclonus. I think usually you can get the cortical ribbon, but only see it in DWI. So that was just one thing that came to mind.
No, that's a great thought, but no, we did get the diffusion weighted and it was normal. That was fine.
Yeah, other things we could have thought about, mitochondrial disease, MRF, mitochondrial, myoclonic epilepsy with ragged red fibers, all of these things. Somebody put SSPE in the chat. I just saw fly by. That's brilliant. Post-measles neurologic condition I've never seen, but is still common elsewhere in the world outside of the United States. But I think they would have neuroimaging, very severe neuroimaging abnormalities actually, and more severe cognitive deficits than what was reported here. So I don't know, Saki, Madalena, any last thoughts here? I think we're all about to learn something.
Yeah, no, this is a very challenging case here. No other thoughts that come to mind. On the chat, I know a lot of people were throwing in SSPE, which is something that can occur after a measles infection. And I think it can occur actually several years after the initial measles infection. So, of course, not an expert on that, but I would assume that imaging would not come back completely negative for that. So that's something
Correct.
that was definitely considering, but given the negative MRI findings, would make that less likely. So I am very stumped, and I'm really excited to learn about what this is and hear the next piece of information.
Yeah, you're exactly right. Yeah, SSP, we should see neuroimaging abnormalities, is my understanding. And I believe more severe encephalopathy would go with that as well. And even though there were cognitive changes, they were at least mild enough on the surface that the patient appeared normal in casual interaction on the first interaction. Okay, Saki, enlighten us.
Okay, so slow myoclonus can be caused by two conditions reportedly, till whatever I've read: Wilson's disease and SSPE. And in India, whenever we see slow myoclonus, the first thing we always think of is SSPE, and more often than not, we're right. So this patient had SSPE. We sent the CSF routine with an IgG and IgM antibodies for measles, and it came back profusely elevated, very, very positive. We asked the mom if she had been vaccinated. She said yes, but she didn't have a card and she didn't know which vaccines she took. So we don't know about that. No history of measles per se, but as I said, it's difficult to obtain histories when, people are not that educated. They just don't know. They just think of it as a rash. So it's something that they don't think about. And yes, so this patient sadly was in stage 2 of SSPE. Stage 2 is when the patient has these movement disorders. Stage 1 is when they have these cognitive difficulties. And stage 3 is fulminant. They become flaccid. Then they have that posturing and then they pass away. It's 100% mortality case, yeah.
And since you're expert in this condition, Saki, what is the sensitivity of MRI findings? Again, I've never seen a
Yes.
case, but
Oh,
my
yes.
understanding was MRI should be abnormal, which was not in this case. Yeah.
Yes, so MRI is not always supposed to be abnormal. It can be completely normal. There are several case reports on that. In fact, and one thing that was deterring our MRI was there was a lot of motion artifact. The patient's mom did not let us sedate her. So that's probably why, but something should have been picked up, but there was nothing. And then that's when I actually went back and Googled, and I was like, oh, MRI is not, it's fine if it's normal. It's normal to have a normal MRI as well in SSPE. So yeah, I think the more cases you see, the more rare kind of findings you bring up. So in the US, if you see SSPE, they'll probably have an abnormal MRI versus, somewhere else.
You made an excellent point I was about to make. First, thank you for sharing this case with us, a condition probably many of us have never seen. And congratulations to the chat. I don't know who said it. I don't have the chat open. I just see things fly by, and I saw SSPE fly by. So whoever or who all said that, brilliant thoughts. And you make an excellent point there, Saki, that when we have conditions that we've never seen, but we've read about, like Wilson's disease is one that came up a few times today, we have this sort of very constrained illness script in our mind, right, of what it's supposed to look like. And as Saki said, if you see a lot of these, then you see the spectrum of how often the MRI is abnormal and what stage of the disease, whereas we're just thinking it's a post-measles diffuse encephalopathy with white matter changes and EEG abnormalities. Makes it really hard to diagnose rare presentations of rare diseases, right? You're expecting the rare syndrome to walk into your clinic, checking the list of boxes for all of the things it's supposed to have, and often not the case. So thank you for enlightening us. And we were close. We thought it was a post-infectious something in a child, and we got anchored on synonyms, but SSP. Fantastic. Well, really brilliant case and presentation, Saki, and really brilliant discussion, Madalena and Mario, working through a very complicated case. Again, none of the three of us got that diagnosis, but I think the journey, we thought through all these elements really well together, and kudos to whoever in the chat figured this out. Great, fantastic. I think Gabby was gonna have some teaching points for us, and then we'll wrap up for today.
Yeah, so thank you, Saki. This case was so great. Madalena and Mario, congratulations for the discussion. I really learned a lot. I've never heard of slow myoclonus before, so I'll definitely check more videos about it. So first we discussed about the definitions of the movements and possible etiologies, because this person had a jerky movements, and these two words can mean either a seizure activity, a movement disorder, fasciculations, or myoclonus, which was the case. And Aaron taught us that the localization of movement disorders, usually it involves the basal ganglia. So it is more useful to use the following divisions to understand the movement disorder better. Is it a structural cause, neurodegenerative cause, a systemic illness, or medication drug use? We also discussed a little bit about olanzapine and valproate, because in this case, they were used to treat the movement disorder, but they can cause a movement disorder by themselves. For example, olanzapine, which is a second generation antipsychotic, can cause secondary Parkinsonism, tardive dyskinesia, and dystonia, and valproate can cause drug-induced Parkinsonism. We also discussed about the complaint this patient had, because she said she had weakness, and we have to understand what is the meaning of weakness. For example, it can mean inability to coordinate or move. It can mean a true weakness, like in the loss of strength, or either patients can say weakness when they have loss of sensation. So the neuro exam will help us to define what is the type of, what the person means when they say weakness. We also discussed some upper motor neuron findings, for example, hyperreflexia, weakness, spasticity, which this patient had, and Babinski sign, which she didn't have as far as I remember, but she had hyperreflexia. And when we have a case with progressive upper motor neuron signs, usually bilateral, with no changes in mental status or cognition, which we thought she had. We localize it to the spinal cord. Usually they have bowel and bladder involvement as well. We also discussed a little bit about a very famous infection that causes a movement disorder, which is Sydenham's chorea, which is secondary to rheumatic fever, strep infection. And we have 2 other anti-streptolism to diagnose that. And a great pearl that I learned today is that there are 2 diseases that have this slow myoclonus, which are Wilson's disease and SSP, which is subacute sclerosing panencephalitis. I really learned a lot today. Thank you so much for the case and for the discussion.
Great, thank you, Gabby. Again, wonderful case presentation. So we all learned a lot, and we'll all keep SSP in our mind. This has been a tour of rare neurology over the past few. We had a Bell-Mouthier case, SSP case. Not all neurology is rare, but we do like our zebras, we have to admit. And thank you again, Madalena and Mario, for the brilliant discussion, and to Chiara for describing all of the details in this complicated case. Have a wonderful day, everyone. See you next Tuesday.
Thank you, everyone.